Okay, welcome to our live stream. It is May 23rd, 2022. 2023. I'm a year behind. And our patient today for the second surgery here is having bad back pain from 2 discs that are damaged. Don't move, Sean.
Hello, my friend. Keep your head down. You're doing great.
The first one is the, just stay still, is the L3-4 on the right side, and the second disc is the L4-5 from the left side. Everyone agree? Right 3-4, left 4-5. Everyone agrees? That's what we're doing. Man, that is, he's got some spondylosis. Probably have to be a little bit lower. I'm going to come from a little bit further off to the side. Shot. Shot. That's looking pretty good. Encountering the facet now. Shot. Deflected. Shot. Wow, that is hard. Really hard. You doing all right? Where are you having discomfort?
Where's your pain?
In the back? Interesting. The facet complex is forcing me just to the end plate. So it's hard for me to get further south. Shot? Yeah. He's not liking that. Let's see if I can get a little bit further south. Shot? All right, so for those of you just joining us, we're performing a procedure called the Deuk laser disc repair. And shot? This is a surgery used to treat painful discs, which this patient has. Shot. He also has painful facet joints, which we'll be treating later. AP. And he also had a piriformis and a ischial tuberosity tendonitis. Ischial tuberosity tendonitis is a problem where the hamstring muscle attaches to the pelvis area, kind of the back of the thigh there. And I need him awake. We're about to do the test. And basically it's treated with an injection, which we did. So yeah, the facets are really forcing me laterally. I cannot get into 4-5.
Just stay nice.
Shot? Huh? Are you talking to me, Henry, or is that the patient?
I believe that was the patient.
Is he okay? Shot? AP? That's incredible. It's just solid bone. Oh, good. We're there. All right. We'll try to get in. I don't think I can get in now. I'll wait till he's asleep and see if we can get in later. All right. Good. Is he cooperative?
How you
So
doing, my friend?
the first thing we do, folks, is we position the patient, prep and drape the back. And then the second thing I do is I gain access to the disc transforaminal through a little hole in the side of the spine. And I know for a fact he's got 2 discs that are damaged that I believe are causing his pain, and he's got some facet joints on the side as well. We're going to treat those later. We're going to start with the disc. All right. Are you comfy? All right. You can understand and hear me.
Don't move your right arm, please. Do not move your arm.
How bad is that on a scale of 1 to 10?
Yes.
How bad is the pain? What's the highest it went?
Give us a number. Can you speak it, please? 3.
That's now, but what was the highest it went?
What was the highest the pain went? You didn't feel much.
All right. You can see the herniation there on the side view. Show us the herniation. Are you going to show us? That's not it. You don't see it arching up? Yep, that's it. Okay? So he's got right leg symptoms. We're going to go in there, and we're ready to put him to sleep, by the way. We're going to go in there and remove the herniation, pinching the nerve.
Try to keep your right hand still for me.
Count out loud for us from 1 to 100, please. So I couldn't get an accurate discogram because by the time he understood what we're asking him, we were done. And I used all the dye. So, oh well.
Try to keep your arm still, my friend.
Keep counting out loud. You're doing great. What'd he say? You can watch later. Don't worry, we'll let you watch the whole surgery later.
Try to keep your right
He
arm
said he
still,
wants
please.
to watch the surgery. All right, shot. Yeah, we don't have patients watch their actual surgery. I know that some places do that. But we want our patients asleep for the painful parts. Keep counting. Out loud. Is he asleep? All right, so he's asleep at this point. We are at the back of that disc, right where the herniation is. Any questions from our audience? Pressure?
No current questions.
All right, well, let's show our audience why is it that a disc in the spine can even cause so much pain. There's a good reason, folks. It's called inflammation. And that's what herniated discs do. They cause inflammation. Big tear there, by the way. That went in really easy. I had no difficulty getting that dilator through the tear. It's so big. Remember, herniations require a tear in order for the herniation to come out of the disc. So all disc herniations have a tear, 100%. It's the tear in the wall of the disc called an annular tear that allows the herniation to occur. Watch out for the cable there. What is that noise? All right. Are you playing the video?
Not yet.
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
Okay, welcome back to the live stream. And now you understand how a disc injury called a herniated disc can actually cause so much pain. It's really due to inflammation within the wall of the disc, the tear. And that's what we discovered here at Deuk Spine as the cause of back pain when it comes from a herniated disc. Now there are other causes of back pain besides herniated discs. Herniated discs account for about 80 80 plus or minus few percent. We don't know the exact number yet. But around 80% of chronic back pain is discogenic, meaning it comes from the disc. And there's only a few treatments that will fix disc pain. One is fusion of the disc. The other is repair of the disc, like you're seeing now, the Deuk laser disc repair. If you don't do those two procedures, there's no way to get rid of that pain. A fusion stops discogenic pain because you have to clean the disc out usually when you do a fusion. So it's not all fusions, it's really inner body fusions with inner body cages at the symptomatic disc. Other types of fusions may not work because they're not really treating the source of pain. All of this white stuff here is scar tissue. This is all damaged disc and herniation. All right. If we don't have any questions, let's move on to how do we fix the disc without having to do fusion.
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
Okay, great. Welcome back. And now you see how the Deuk laser disc repair surgery works. It really targets the source of back pain, which is the inflammation within the annular tear. By cleaning out the annular tear, we call that a debridement. We're removing not just the herniation stuck in the tear, but also scar tissue, dystrophic calcium deposits, this orange stuff here, and inflammatory tissue that's in there. So there's a lot of debris, scar tissue, inflammatory tissue, calcium deposits, and herniated nucleus pulposus. That's really what we're removing. We also can remove some bone spurs around the herniation if needed. We don't remove all the bone spurs. And as I've said many times before, we don't take the whole herniation out. It's not possible. There's the tear, by the way. You see the blue stuff? It really shows you where the tear is nicely. The blue stuff is the jelly in the center of the disc that has squeezed out into the tear and is sitting inside the tear, causing this pink stuff. You see the pinkish color there? Faint pink? That's all blood vessels, inflammatory blood vessels within the annular tear. That's where all the pain comes from. Yeah, this fiber, because of the way the tip is, I think for some reason it's just not directing the laser energy as effectively. It's not bad. I mean, we're still getting it done. It's just taking a little longer. It's less efficient. You can actually cut across the glass fiber, right?
Oh yeah, yeah.
And you can. It would be interesting to see the effect of straight cut versus angled. You know, to see if there's a difference. You know what I mean? If there's a difference when you cut the surface. Because what I think happens is when you have a straight cut, it allows the entire surface, the flat surface, the whole circle, to work properly. But when you have a diamond, like an angled cut, beveled cut, then it directs the energy through the bevel and there's less surface area interacting. That's a Valsalva maneuver by the patient. You guys see that? That's a cough. Sometimes the patients cough while they're asleep, and you can see that Valsalva. Just like if you coughed, you could see the pressure they put on their discs. Everything kind of bulges into the tube. This is all scar tissue, by the way, from chronic inflammation. Years and years of inflammation, pain in his disc. Massive amounts of scar tissue. All the white stuff, scar tissue. You guys see all that? Then the blue stuff is the herniation. Fresh herniation. Newer. All right, any questions from our audience? We're almost done. We're almost done with this disc, Dr. Berndes. Like I said, the next one, he looks like he's actually almost auto-fused the disc. That's what it feels like. So I don't know how much we're going to get, but we'll try. Get as much as we can, and then we're going to move on to the facets. This patient came to us with horrible back pain right at the L3-4, L4-5, kind of L5-S1, but more to the right side, which is the side I'm on. And when I did my exam of him, I noted that not only did he have problems with pain coming from the discs, but definitely he had facet pain. And I was telling you earlier that 80% of back pain, plus or minus a few percentages, is from the discs being damaged. The other 10% is coming from the facet joints. Facet, F-A-C-E-T joints. And then the rest of it comes from the SI joint, the piriformis muscle, and the coccyx, fractured vertebrae. So just to put everything into perspective, if you have chronic back pain, it's probably coming from your discs. There's at least an 80% chance it is. Just about done. Maybe 30 seconds more. Here's the epidural space. Here's the final outer fibers of the annulus fibrosus that have been damaged. And intermixed in there is scar tissue. That's what the short white stuff is. This stuff, all this is scar tissue from just inflammation going on for 10, 20, 30 years. I think he's had pain in his back for a long time. I want to say 40 years if I remember correctly. Right? All right. 40? Yeah, 40 years. 40 years. 40 years of back pain. Think about that. What the impact is on quality of life when you have 40 years of back pain. That's sad. It's basically being handicapped for 40 years. All right. We're done. I don't see anything more that I can do. I think he's going to be happy with these results.
Lights on, please. Thank you.
Any questions from our audience so far?
Yes, we have a question from Severin on YouTube.
Hello, Severin.
They asked, why doesn't the nucleus/gel come out again through the annulus after the hernia is removed?
Great question. The answer is it can. You are correct, it can. So what keeps it is the patient not doing any strenuous activities. We give all of our surgery patients that have the Deuk laser disc repair restrictions on bending and lifting. And if you just follow those simple restrictions for a period of time after the surgery, there will be no reherniation. And the reason is because the gel is not liquid, it's a semi-solid. It's actually a lot firmer than most people would suspect. So it doesn't just run out, okay, like everybody thinks. It actually doesn't want to come out unless the disc is put under pressure. And the way you get your disc under pressure is by lifting heavy things. Pressure? Let's do the RFA here first. Stay there. Stay there. Yeah, we're going to do the, not RFA, but DPR. Sorry. Lay still. Everything okay? Yep, I'm good. We're gonna move on with the DPR, Deuk plasma rhizotomy, as the next procedure. Shot. All right, so to do the DPR, I need to see L3, L4, L5, S1. Pretty good. All right, let's get started with 3. I'll take a needle. All right, so for those of you who don't know what we're doing, we're actually treating his facets. You have any num-num? I'm going to put the needle down right here. Let me have the num-num. Thanks.
I'm going to need more light on, please. Thank you. And an 18 gauge, please. Thank you.
Shot. All right. Not too bad. We're heading in the right direction. Need to be a little bit higher. Shot. That looks good. That feels good at least. I feel the transverse process. That looks good. Shot. That is the not quite the perfect spot, but we're going to get there. Go ahead. Show us, Jordan, on there where the perfect spot is. That's right. That's right there. See where the arrow is, Henry?
Yes, we do.
That is the perfect spot. So now we're going to target that with our probe, and we're going to treat this patient's facets. Shot. A little too high. Shot. Oh yeah, much better. And I want to go medial. Oh, stay there. Stay there. Where are you going? Huh? Shot? Where were you headed? Shot? Man, just a tiny movement is incredible. Shot? Right? How much you get. That is the spot. So I'm actually killing his pain nerve at the L3. And it's called the medial branch of the dorsal ramus. That's good. They all are. But take your time. We're good. He's doing great. Okay. Now, interesting. You guys see the transverse process of L4? It's very different. Hey, Jordan, show us the facet joint at L4, L4-5. That's right. There's the joint. Show us the TP. The TP is short. Actually, it's right there. It's really abnormal, to be honest. It's an abnormal transverse process. Now, he's not had back surgery before, right? So it's not like that's been surgically altered. Look at the transverse process of 3. Show us that. There it is. Look at the transverse process of 4. This totally abnormal TP. Yeah. So, all right. Now I'm going to go through the same incision, and I'm going to head down to that next target, which will be shot. It's too high. Shot. That's a little bit better, but too lateral. Shot. That's very close to where we need to be, actually. And I feel the bone, by the way. I want to be a little bit more medial. Shot. It's important that you stay on the transverse process, the bone. You got to feel it. That's perfect. It doesn't get any better than that. You guys see where the tip is? Right where the superior facet meets the transverse process. That's where we want to be. So we're going to do our second burn. Again, this is called the Deuk plasma rhizotomy. For those of you who have had facet joint treatments, you've probably had an RFA done. The problem with RFA is it doesn't last. RFAs wear off. And when they do, shot? Well, they do. The problem is you got to keep coming back for more, which, hey, that's great for the doctor. Doctors love when patients keep coming back for more treatment, right? But it's not good for the patient. I'm right on that bone. Like I said, very abnormal transverse process for him. Very abnormal anatomy. Shot, I want to make sure. Yep, it's perfect. So I'm moving it around, I'm hopping. Dr. Patel and I talked about this today. It's a hop and a slide. And we call it the Deuk spine hop and slide. Shot? No, see where the tip is, guys and gals? That is literally the perfect spot. That's where you want to be. Okay, and I'm making sure I'm getting that nerve, that pain nerve. I'm burning all around there. Okay? Because I don't want to have to come back and do this again. So you want to take your time and get it right. How's he doing? Good? Shot? All right. Now this next one is tough, but you can see it. I'm almost perfect where I am. Almost perfect. That's probably going to be it right there. Oh, perfect. You guys see that? No, one more. I got this, one more, and then I don't think I can do anything on that other side. The disc is fused. Yeah, just I need like 3 more minutes. We're done. 2 more minutes. We're done. Yeah. Go ahead. I command you. Your hand becomes my hand. Watch out for that. Remember Maradona? The hand of God? Yeah. Did you watch soccer back then in the 80s? Yeah. You know what I'm talking about?
Yeah, I know what you're talking about.
Everybody knows, right? Shot? Too low.
20 watches in the hand.
20 what?
Yeah, he had a bunch of watches. He was crazy at one point.
Was he really? I don't know. I just know that he used his hand to hit the ball in.
He just removed his clothes and run in the field.
Did he really? Oh my God. It's terrible. Maradona. We're talking about Maradona. Diego Maradona. That's he was many people's what do you call it? Hero, right? When they were young. Shot. Okay, we're trying to get to the right spot, and I'm a little bit lower than I want to be. I want to be a little higher. There, that's probably better right there. And I'm trying to get my hand out of the way with the instrument out of the way so we can all see. That's perfect right there. You agree, Jordan? Jordan is very agreeable. That's the one thing I like about Jordan. It doesn't take much convincing.
You're a good man, Jordan.
He's a good man. He's really a good boost for my ego, you know? All right. Again, this patient has abnormal transverse processes. Sean, let's see where that is. You agree, Jordan? Look at that thing. I mean, it's so abnormal. Woo! There's like he was born with abnormal transverse processes. Okay? Real skinny, not formed normally. They are not normal. So it makes this thing harder to do. And shot? Wait, shot? Oh yeah, that's nice. It makes it harder to do because you have smaller targets. Shot? Oh, no. Shot? That's good. Anyway, I started doing these procedures. I've been doing these rhizotomies for many years and never really knew that I was actually doing them, because they're part of a fusion surgery that I do, and I was really impressed, with how much pain relief patients got with fusion. And I realized that part of that probably was the effect of this procedure, the Deuk plasma rhizotomy being done at the same time. Shot? Oh, what do you think, Luis? All right, that's good. One more to go. Our last one is our sacral target. It's right at the junction of the shot at the superior articular process with the sacral wing. I'll show you in a moment because I will not stop till I get it exactly right. That's almost right. Shot. Just a little movement of the needle really changes the trajectory. So that's the perfect, just medial to that is the perfect spot. Shot? Yeah. And I can't get any more medial because there's some arthritis pushing me, but we're going to sweep that whole area with the probe. So once again, we do a hop and a sweep to make sure we get that medial branch of the dorsal ramus. Hop and sweep, hop and sweep. Shot. Too low. That feels better. Shot. Too low. Shot. That's much better. So what you guys are getting to see today is how we doctors use image guidance, what's called image guidance, to guide our instruments in the body to a certain target, okay? And without it, we wouldn't be able to do spine surgery. Spine surgery always requires image guidance, 100% of the time. It's not possible to do spine surgery without image guidance. So the most common form of image guidance is X-ray. Shot? That's not bad. I can feel the bone there. X-ray, 30 seconds. Let's have a little depomedrol. Shot. Oh yeah. Thank you, Luis. Because that's all we're going to be able to do there. All right, I feel like I got the nerve good, and we're done. Great job, everyone. You guys are awesome. Let's show the audience the incisions. Henry, can you see this?
Yes, we can.
So for the Deuk plasma rhizotomy procedure, just forget about the, oh, I need a stitch. Forget about the Deuk laser disc repair. That's this big one, which is not big, by the way. It's a sonometer, 10 millimeters. But look at the Deuk plasma rhizotomy. It does require an incision, but they're 3 millimeters. They're 3 millimeters. And typically with each incision, I can get kind of 2 nerves. And this patient needed 5 nerves. All right, 3, 4, 5, actually 4 nerves burnt. So I was able to get 2 with each incision. I'm going to put 1 stitch for his incision for the DLDR, not the DPR, but the DLDR. And then do we have any questions?
No current questions.
All right, let's go ahead and end the broadcast, and we'll be back again shortly for our next surgery. What is the next surgery? Is that the thoracic?
No, lumbar one.
Why? You guys are saving thoracic for last? Huh?